Welcome to the deep dive. Forget skimming the surface. Today, we're plunging into a topic that's absolutely, well, non-negotiable for anyone serious about healthcare. Preoperative assessment and optimization.
That's right.
We're really taking a scalpel to our source material here, excerpts from a highly respected surgical text to extract every single vital piece of knowledge.
Absolutely. Our mission in this deep dive is total immersion. We're not just, listing facts. We're digging deep into the why behind the whole process.
Right.
The nuances of identifying risk, the strategies for managing these complex patients. By the end, you should really have the kind of depth of understanding in preoperative care that sets apart the elite professionals in the field.
Okay, let's roll up our sleeves and get straight into it then. The sources kick off by reminding us just how much physiological stress major surgery actually piles onto the body. It's a serious challenge.
Oh, absolutely. Think of it like putting the body through an intense marathon it wasn't necessarily trained for. You see this huge spike in oxygen demand, potentially, up to 40% above baseline.
40%, that's significant.
It really is. And alongside that, you get this whole cascade of inflammatory responses, cytokines flooding the system, hormonal shifts, a heightened tendency for blood clots to form.
Right, hypercoagulability.
Exactly, and major fluid shifts, too. These aren't just fleeting issues. They can disrupt the body's equilibrium for days, days after the operation.
So the entire goal of preoperative planning is essentially to kind of condition the patient, to shore up their defenses and minimize those stressful, unwanted physiological effects.
Precisely. It's about proactively giving the patient the best possible platform, the best possible start to handle that surgical insult and recover as smoothly as possible.
How does that process actually work in practice?
It's systematic, usually centered around a dedicated preoperative clinic. It involves a really deep dive into the patient's history, a thorough physical examination, and then targeted investigations. The core goal is always to assess their functional reserve, basically, how much capacity their organs actually have left. Then, based on that, you plan how to optimize their health and anticipate the specific stresses their planned surgery will create.
Where do you even start pulling together all that information? Seems like a lot.
Existing records are gold, absolute gold. Patient notes from their primary care physician, previous hospital admissions, they provide that crucial baseline understanding of their health journey.
And it's not just one person doing this assessment, is it? The material really emphasizes the team approach.
Oh, it's fundamentally multidisciplinary. You've got input from primary care, specialist nurses, physiotherapists working on fitness, dietitians addressing nutrition.
All those different angles.
Exactly. And often a perioperative physician overseeing the more complex cases. This team works together to get chronic conditions under control, address lifestyle factors like weight and smoking, and initiate prehabilitation, getting patients fitter before they even get near the operating room.
Prehabilitation, that concept, seems to be getting so much traction now. Proactively building resilience.
It really is. And it works. And then you have the surgical and anesthetic teams who bring it all together, using this comprehensive picture to craft the safest possible plan for that specific patient's operation and anesthetic.
I like that the source mentions simple questionnaires can sort of kick things off.
Yeah, they're great screening tools. They can quickly flag potential risk factors, which then directs the team towards which specific tests are needed or, what optimization steps should be the priority.
And what if someone has particularly complex health issues or they're facing a really high-risk procedure?
That's when you bring in the specialists. Referral to cardiology, respiratory, other experts is crucial. They can provide a much more granular assessment of the specific risks posed by, say, severe heart or lung disease, and guide targeted interventions to reduce those risks as much as possible before surgery.
And all this assessment, all this planning, it culminates in that crucial conversation with the patient, doesn't it?
Absolutely. This is where the risks of the surgery and anesthesia are laid bare, really. You discuss how their existing health conditions influence those risks and the potential outcomes.
Which, as the source touches on, is fundamental to truly informed decision-making. The patient needs to be a partner in this.
Exactly. And beyond just the big picture risks, there's also practical advice given. Fasting times, specific instructions about their regular medications, which ones to continue, which to pause, and if they need any particular pre-medication before arriving for surgery.
And finally, the material even covers the logistics actually arranging the theater list itself.
Yes. The surgeon, the anesthetist, senior theater staff are all involved. And a key safety step, adapted from the WHO checklist, is the team brief before the list starts.
The brief, yeah.
It ensures everyone is on the same page about the patients, the plan, any potential challenges. It sounds simple, but it's incredibly powerful for safety.
So that's the overarching framework, the why and the how.
Okay,
Let's pivot now and really dissect the foundation, patient assessment. And where else to start but with history taking?
History is your roadmap. It really is. You need to systematically gather past medical and surgical history and conduct a thorough system-by-system review, cardiovascular, respiratory, everything.
The source highlights needing to document important negatives. That phrase always catches my ear. What does that really mean in practice?
It's vital. It means specifically asking about significant conditions and documenting that the patient denies them. For example, when assessing someone for major surgery, you must specifically ask, have you ever had chest pain on exertion? Or any history of shortness of breath when lying flat?
So you're actively ruling things out.
Precisely. Table 21.1 in the source provides a really comprehensive list of these critical negatives across all major systems that you need to actively inquire about. It shows you not just passively listening, you're actively screening for those hidden risks.
I can see why knowing about past surgeries and anesthetics is so critical.
It offers clues about potential future problems, doesn't it? A previous abdominal operation might mean adhesions, which changes the whole approach for laparoscopic surgery. A history of a difficult intubation is a massive red flag for anesthesia planning. Or a family history of a rare issue like malignant hyperpyrexia. You absolutely have to know about that.
Recreational drug and alcohol use are also specifically mentioned.
Yes, because they have documented associations with worse outcomes perioperatively. And of course, a complete list of all current medications and any allergies is just non-negotiable baseline information.
And the social history, not just the purely medical stuff.
Exactly. Understanding the patient's home environment, their communication abilities, their baseline mobility, it's crucial for planning beyond the operation itself. You're thinking about admission logistics, realistic discharge planning, and what level of rehabilitation they might actually need.
Okay, so from the conversation, we move to laying on hands, the physical examination.
Always approach the patient with respect and dignity. That's paramount. Clearly explain every step of the examination and ensure their comfort. And remember, a chaperone should always be offered and present for intimate parts of the exam, following local guidelines. Summary box 21.2 in the source gives a good, concise overview of the key examination areas.
It notes looking for general findings, even if they don't seem directly related to the planned surgery. Why is that?
Because they can reveal underlying health issues you might have otherwise missed. Are they pale, suggesting anemia? Jaundiced, maybe liver problems? Cyanotic, low oxygen? Do they look frail? What's their nutritional status like? Are there any potential sources of infection like poor teeth or skin ulcers? And basic measurements like height, weight, and BMI are fundamental.
And you get more focused.
Yeah, you examine the area of the planned surgery, correlating your findings with any imaging results you have. You do a systemic check to gauge the impact of any comorbidities you found in the history. How limited are those organs, really? Table 21.2 lists the systems to focus on, and you might need specific checks related to the surgery itself, like assessing if they can actually be positioned safely on the operating table.
The source really hammers home that the minimum absolutely necessary exam includes cardiorespiratory and airway assessment.
These are non-negotiables because problems here are just such high stakes. You're listening for signs of heart failure, valvular heart disease, checking for peripheral vascular issues, and assessing the severity of any respiratory disease.
What specifically are you looking for?
Well, Table 21.2 gives concrete examples. Checking their pulse, blood pressure, listening to their heart and lungs, looking at their neck veins, the JVP, checking for fluid retention edema, but critically, assessing their exercise tolerance.
Right, how much can they actually do?
Exactly. How far can they walk? Can they climb stairs without stopping? What's their respiratory effort like at rest? What's their oxygen saturation? And importantly, does it drop with even minimal exertion? Measuring their peak expiratory flow rate, PEFR, gives an objective measure of large airway function too.
Let's spend a moment just on that airway assessment because the source flags it as absolutely critical, saying a failure to plan.
Can indeed have fatal consequences. It's that serious. While predicting a difficult airway isn't foolproof, we assess several parameters to try and estimate the risk.
The Malampati classification is probably the most well-known one.
Yes, the modified Malampati test. You ask the patient to sit up, open their mouth wide, and stick out their tongue without saying, ah.
Right.
Grade 1, you see everything clearly, the back of the throat, the pillars, the uvula. Grade 4, you can basically only see the hard palate. Table 21.3 spells out the 4 grades. It's interesting, the source notes it was originally just 3 classes described by Dr. Malampati and later refined to 4 by Samsoon and Young.
What else are you looking at beyond Malampati?
Mouth opening ideally greater than 3 centimeters. Figure 21.1 illustrates what that kind of gap looks like. The thyromental distance, that's from the tip of the chin to the notch of the thyroid cartilage, needs to be more than 6.5 centimeters ideally.
Okay.
And the thyrosternal distance from the thyroid cartilage down to the sternum over 12.5 centimeters is generally good.
And mobility. How much they can move their neck and jaw.
Crucial. Can they protrude their lower jaw forward? Figure 21.2 shows that motion. And can they extend their head back at the atlanto-occipital joint, the joint right at the base of the skull? Figure 21.3 demonstrates that head tilt. Limited mobility here makes aligning the airway for intubation really difficult.
The source points out that if you find abnormalities in multiple of these tests, the chance of a difficult airway goes up significantly. It's not just one factor.
Exactly, it's cumulative. And other factors add to the challenge too. Poor or absent teeth, a big beard, any masses, scarring, or active infections in the upper airway, significant obesity, or a very large neck circumference.
There's lots to look for.
But honestly, the most valuable piece of information is often from a previous anesthetic chart if they've had an airway problem documented before, or if they have a specific alert in their notes flagging a difficult airway. That's gold dust.
So, DEVE history, detailed physical, including that laser focus on the airway. Now let's get into the data, the investigations.
Yeah, guidelines like the UK's NICE or the US ASA provide guidance here, suggesting tests based on the patient's risk level and the planned surgery. But the key insight from the source, I think, is that not every test is needed for every patient. It's about being selective and targeted.
So walk us through when some of these common tests are indicated. The full blood count, FBC. When's that essential?
Essential for major operations, definitely in elderly patients if you suspect anemia or ongoing blood loss, or if they have significant chronic disease that might affect their blood counts.
And HbA1c.
If they have diabetes and their HbA1c hasn't been checked in the last 3 months, you really need it. It gives you that snapshot of their average blood sugar control over time.
Sickle cell test. Routine?
No, not routine at all. Only if there's a clinical suspicion of sickle cell disease or a relevant family history suggesting they might carry the trait or have the disease.
Okay. Urea and electrolytes? UNEs. Seems common.
Needed for all major surgeries, patients over 65, anyone with known heart, kidney, or endocrine disease. Also crucial if significant blood loss is anticipated during the surgery, or if they are on medications that can affect electrolytes.
Like we mentioned earlier.
Exactly, certain diuretics, steroids, digoxin, NSAIDs, and also if they are receiving intravenous fluids or nutrition or have known endocrine problems.
What about liver function tests, LFTs?
You'd request those if there's any hint of liver problems. Maybe they're jaundiced, you suspect hepatitis, cirrhosis, or malignancy. They have a history of significant alcohol use, or if they're significantly malnourished.
Clotting screen. Coagulation studies.
Definitely if they have a history of bleeding themselves, known liver disease, conditions like eclampsia or cholestasis, if they are on blood-thinning medications, anticoagulants, or antithrombotics, or if there's a family history of bleeding disorders.
The source makes a really important point here about standard tests.
Yes, it's critical. Standard clotting tests like PT and APTT do not tell you about the effect of antiplatelet drugs like clopidogrel or the newer oral anticoagulants that target factor ZA like rivaroxaban or apixaban. You need a specific history for those drugs.
ECG. When's that needed?
An electrocardiogram is generally needed for patients over 65, anyone reporting cardiac symptoms like chest pain or palpitations, or those with a significant history, things like rheumatic fever in the past, diabetes, or known significant heart, kidney, brain vessel disease, or severe respiratory problems.
It depends on the surgery size, too.
It does. The decision also depends on the magnitude of the surgery. NICE classifies them as minor, intermediate, or major. Figure 21.4 in the source shows an ECG pattern suggesting a recent heart attack, for example, which is critical info, while figure 21.6 shows complete heart block, another major finding.
Chest x-ray. Used to be routine, wasn't it?
It was, but not anymore. Only if your clinical exam raises a specific concern about their lungs or heart that needs imaging. It's not a routine preoperative screening test now.
Echocardiogram. An ultrasound of the heart.
That's indicated for patients who are symptomatic with heart murmurs or show clinical signs of heart failure. If they have known valve disease or prosthetic valves, you need a recent echo, especially if their symptoms have changed recently following local protocols for surveillance.
Urine tests. dipstick or culture?
Only microscopy and culture if finding a urinary tract infection would genuinely change the decision to operate or the timing. For instance, before a joint replacement where introducing bacteria is catastrophic. Otherwise, it's not routine screening for asymptomatic bacteriuria.
And a pregnancy test, beta-HCG.
This requires real sensitivity. You need to ask women of childbearing age about their pregnancy status, as a positive result clearly impacts planning and the consent process. If pregnant, obstetric advice is essential, and the consent must explicitly address the risks to the fetus. And importantly, consent for the test itself should ideally be obtained on the day of surgery.
The source lists a few more specialized tests as well.
Right. Things like measuring venous bicarbonate can sometimes flag patients at high risk for obstructive sleep apnea, potentially leading to formal sleep studies if there's time. Arterial blood gases give rapid critical information in patients with severe acute or chronic respiratory failure. Or if there are complex acid-base disturbances, like you might see in some kidney patients undergoing transplant.
And blood grouping.
You'll need a blood group and cross-match sample taken if you expect the patient is likely to lose more than 500 milliliters of blood during the surgery.
And don't forget the swabs.
No, MRSA and now often COVID-19 screening are pretty standard in many places. Spirometry might be needed to assess lung function more formally in some respiratory patients. Cardiopulmonary exercise testing, or CPET, is the gold standard we'll discuss later for assessing fitness for high-risk surgery. And sometimes specific radiological views are required during the surgery itself, so that needs to be planned and discussed with radiology beforehand.
So we've gathered all this incredible data from the history, the exam, and the targeted investigations. The next huge step is managing the problems we actually find. Let's try and go system by system, focusing on the most common preoperative challenges and how the sources suggest managing them.
The overarching principle is really quite simple. Optimize any identifiable problems to the best possible level before surgery. If a patient has severe disease in a particular system, referral to the relevant specialist is absolutely non-negotiable.
And that referral needs to be good.
Exactly. That referral letter needs to be comprehensive, summarizing your key history findings, the pertinent exam results, and the investigation outcomes. Give the specialist everything they need.
Okay, kicking off with cardiovascular disease. The source points out it's a leading cause of perioperative complications. No surprise there, really.
It is. A simple assessment like asking if they can climb a flight or two of stairs without getting symptoms can be a quick initial indicator, though it is subjective. The real focus is identifying those patients at high risk for a major adverse cardiac event, what we call MEC, specifically around the time of surgery.
What are those key MCE risk factors according to the source material?
Existing ischemic heart disease, IHD, heart failure, even if it seems compensated now, significant arrhythmias, severe peripheral vascular disease, a history of stroke or TIA, significant kidney problems, or if they are undergoing major surgery within the chest or abdomen. Those are the big ones.
Okay. For patients with known ischemic heart disease, IHD.
If their angina isn't stable or well controlled, they absolutely need cardiology assessment before any elective surgery. The indications for procedures like coronary stenting or bypass before non-cardiac surgery are generally the same as they would be. Otherwise, you treat the cardiac problem if it warrants treatment on its own merits first.
What about their medications? Beta blockers, statins.
Pharmacological protection is key here. If they are already on beta blockers and statins, they should definitely continue them through the perioperative period. If they aren't on a statin but are having major surgery, consider starting one preoperatively, especially if they have other vascular risk factors.
And other cardiac meds.
Most long-term cardiac medications are continued. However, ACE inhibitors and ARBs, angiotensin receptor blockers, are often paused about 24 hours before surgery.
Why stop those specifically?
Mainly to reduce the risk of significant hypertension, low blood pressure during anesthesia and surgery. They are usually restarted the day after surgery if everything is stable.
How else is IHD assessed preoperatively beyond just symptoms and the baseline ECG?
Stress tests can be useful, things like exercise ECG, stress echocardiography, or myocardial perfusion scans, scintigraphy. The source notes they have a high negative predictive value, meaning a negative test makes significant IHD unlikely. But their positive predictive value isn't as strong. Techniques like fractional flow reserve during coronary angiography are more precise for identifying which specific coronary blockages are truly flow limiting.
What if a patient has recently had a heart attack, an MI?
Elective surgery should definitely be delayed. ideally for 3 to 6 months after a confirmed MI, like the example ECG shown in figure 21.4. This dramatically reduces the risk of having another heart attack during or shortly after the non-cardiac surgery. Even silent ischemia found incidentally on a preoperative ECG warrants discussion with a cardiologist.
Hypertension control, high blood pressure.
You really want to aim for a blood pressure below 160/100 mmHg before elective surgery. If you need to start a new antihypertensive medication to achieve that, allow at least 2 weeks for it to take effect and stabilize before proceeding with surgery.
Heart failure sounds particularly high risk, based on what you said earlier.
It is. Any degree of left ventricular dysfunction increases risk, but patients with ejection fractions below 35%, especially if their condition isn't fully optimized medically, are at the highest risk for multi-organ failure after major surgery. You must assess their functional capacity carefully.
So surgery might need to be delayed.
Often, yes. Delay for an echocardiogram if one hasn't been done recently, and for optimization of their medical treatment, usually guided by a cardiologist. BNP levels B-type natriuretic peptide can be a helpful blood test marker for severity and prognosis in heart failure.
And their heart failure medications, continue them.
Continue beta blockers, definitely. ACE inhibitors are often continued too, unless there's a specific concern about kidney perfusion or blood pressure. Any patient with a known ejection fraction below 35% needs specific discussion with cardiology before major surgery. Cardiac resynchronization therapy, a special type of pacemaker, might even be considered if their ECG tracing meets the criteria, as it can improve heart function.
What about drug-eluting stents, DES? Those coronary stents, how do they affect surgery timing?
This is a tricky area. Patients with these stents are typically on dual antiplatelet therapy, usually aspirin plus another agent like clopidogrel for at least a year to prevent the stent from clotting off, which can be catastrophic.
So surgery within that year is risky.
If non-cardiac surgery is absolutely necessary within that 12-month window, the decision to continue or stop one or both antiplatelets is really complex. It requires a careful, multidisciplinary discussion involving the surgeon, cardiologist, anesthetist, and the patient, weighing up the risk of surgical bleeding versus the devastating risk of the stent thrombosing if you stop the meds.
Okay. Dysrhythmia like atrial fibrillation, AF.
For patients in chronic AF, you continue their rate control medications, things like beta blockers, digoxin, or calcium channel blockers. New onset AF or atrial flutter needs prompt investigation and treatment before elective surgery. Sometimes cardioversion to try and restore normal rhythm might be considered, as it can improve cardiac output by up to 15%.
And other rhythm issues.
The source also notes other arrhythmias seen on ECG, like significant fast or slow heart rates, or any degree of heart block, definitely require cardiology input before proceeding with elective surgery.
What about specific types of heart block, like Mobitz to second or third-degree heart block, shown in figure 21.6?
Those often require a temporary or even permanent pacemaker insertion before major non-cardiac surgery, and absolutely need discussion with cardiology first. The source gives a nod to Woldemar Mobitz, who first described these specific ECG patterns.
Managing anticoagulation seems like a potential minefield. Let's start with the classic, warfarin.
Right. For most surgeries, warfarin needs to be stopped about 5 days preoperatively. The goal is to allow the INR, the international normalized ratio, to fall to 1.5 or below. That level is generally considered safe enough regarding bleeding risk for most surgical procedures.
And the newer oral anticoagulants, the DOACs, dabigatran, rivaroxaban, apixaban, edoxaban.
These are different. They don't have readily available or rapidly acting reversal agents like warfarin does with vitamin K. They also need to be stopped before surgery, typically 2 to 3 days beforehand if the patient's kidney function is normal, but potentially longer if kidney function is impaired, as they're cleared by the kidneys.
Is bridging with heparin usually needed when stopping these newer agents, like it often is with warfarin for high-risk patients?
Generally, no, not usually with the DOACs, unless the patient has a very high underlying risk of clotting, for example, a very high CHA2DS2 VAS score predicting stroke risk in AF. The decision to bridge, regardless of which anticoagulant they're on, always involves balancing that risk of a stroke or other clot if you stop the medication versus the risk of major bleeding during or after surgery if you don't stop it long enough, or if you use bridging heparin too close to the procedure.
And a critical point from the source regarding mechanical valves.
Yes, very important.
Yeah.
These newer direct oral anticoagulants are not licensed for patients with mechanical heart valves. Warfarin remains the standard anticoagulant for those patients.
Okay. What about patients with pacemakers or implanted defibrillators, ICDs?
They need a preoperative check and potentially reprogramming by a cardiac device specialist or technician. The main concern during surgery is the use of monopolar diathermy, the electrical surgical knife.
Why is that a problem?
It can generate electrical interference that the device might misinterpret. It could potentially sense the diathermy noise as the patient's own heart rhythm and inhibit pacing when it's needed, or in the case of an ICD, it could potentially mistake the interference for a dangerous arrhythmia like VF and deliver an inappropriate shock.
So what do they do?
Defibrillation functions are usually temporarily turned off, or the device is reprogrammed to a non-sensing pacing mode, like VOO, during the surgery. Using bipolar diathermy is generally safer as the electrical current is more localized between the tips of the instrument. The source even notes the historical link to Friedrich Trendelenburg regarding patient positioning, which can also affect device leads.
Valvular heart disease. Leaky or tight valves.
Even moderate valve disease can significantly alter anesthetic planning. Patients with severe aortic stenosis or severe mitral stenosis in particular may actually benefit from undergoing a valvuloplasty procedure, stretching the valve open before major non-cardiac surgery to improve their cardiac function and reduce perioperative risk. Referral to both the anesthetist and cardiologist is essential here.
And investigations for valves?
An echocardiogram is definitely needed if you hear a new murmur on examination, or for patients with known significant valve issues or those with prosthetic valves, especially if their symptoms have changed.
What if they have a mechanical heart valve replacement?
These patients absolutely must have their warfarin stopped before surgery, but they require bridging anticoagulation, usually with intravenous heparin or subcutaneous low molecular weight heparin, to prevent the artificial valve from clotting. This complex management needs close liaison with a hematologist. Bridging therapy continues after surgery until their warfarin is back in the therapeutic range, again, always carefully balancing the clotting risk against the surgical bleeding risk.
Lastly, on the cardiovascular side, the source discusses cerebral vascular disease patients with a history of stroke, or TIA.
Patients who have had a stroke face a higher risk of major adverse events, including MI or another stroke after subsequent surgery. The risk is highest in the first 3 months following the stroke.
So ideally postpone surgery.
If possible, elective surgery should ideally be postponed for at least 9 months after a stroke to allow this heightened risk to decrease substantially. When surgery is necessary sooner, balancing any antiplatelet medication they might be on weighing the risk of surgical bleeding versus the risk of another thrombotic event requires that careful multidisciplinary discussion involving the surgeon, anesthetist, and often a stroke physician.
Phew, that's a huge amount to consider just for the cardiovascular system. Let's shift gears now to respiratory disease. The source states clearly that postoperative respiratory complications are a major cause of morbidity and mortality, especially after abdominal and thoracic surgery.
They really are. Pneumonia, respiratory failure. They're serious problems. It's critical to understand how limited their breathing is now compared to their usual baseline state.
What are the key markers of severe respiratory disease that significantly increase perioperative risk? Things that really flag a patient as high risk.
The source lists several important ones. A forced expiratory volume in the first second, FEV1, that's less than 30% of what's predicted for their age and size, needing oral steroids regularly to control their symptoms, requiring home oxygen or non-invasive ventilation, or having a chronically high level of carbon dioxide in their blood when breathing air. A PaCO2 consistently greater than 6 kPa. These all indicate very limited respiratory reserve and a high risk of postoperative pneumonia or respiratory failure.
How do you manage these respiratory conditions preoperatively? What optimization can be done?
First, ensure they are compliant with their regular inhaler therapy, that it's optimized. If they have brittle asthma, they might need extra steroid cover around the time of surgery to prevent an exacerbation. Encourage smoking cessation, even stopping just a few weeks beforehand helps lower carbon monoxide levels in the blood and improve sputum clearance from the airways.
And prehabilitation comes in again here.
Yes, specifically inspiratory muscle training. There's good evidence showing it can make a significant difference in improving lung function and reducing the rate of post-operative chest complications in at-risk patients.
What about the surgical technique itself for these patients? Does that change?
You definitely consider less invasive approaches if they're appropriate for the condition, or using regional anesthesia instead of general anesthesia if suitable, as these put less stress on the respiratory system. And critically, if the patient is having an acute chest infection or an exacerbation of their underlying lung disease, elective surgery should absolutely be postponed until they've recovered.
When is a referral to a respiratory specialist warranted?
If the lung disease is severe or seems to be worsening despite treatment, if they're planned for major surgery and have significant coexisting lung problems, if they show clinical signs suggestive of right heart failure secondary to lung disease, like breathlessness, fatigue, ankle swelling, enlarged liver, or if they're a young patient presenting with severe, unexplained respiratory problems, which might suggest a rare underlying condition needs investigating.
Okay, let's move down the body to the gastrointestinal system. A big concern here, especially with anesthesia, is regurgitation.
Absolutely. With general anesthesia or deep sedation, the protective airway reflexes like coughing and swallowing are suppressed. If stomach contents are regurgitated, they can be aspirated into the lungs, causing aspiration pneumonitis or pneumonia, which can be very serious. That's why preoperative fasting is absolutely non-negotiable.
What are the standard fasting times people need to adhere to?
The usual guidelines are 6 hours for solid food and non-clear fluids, like milk or juice with pulp, 2 hours for clear fluids only, things like water, black tea, or coffee without milk, clear apple juice, and 4 hours for breast milk in infants.
The source makes a point about avoiding prolonged fasting, though.
Yes, because excessive fasting can be detrimental to the patient's recovery and metabolic state. You should stick to the recommended minimum times. However, for patients who are known to be at higher risk of aspiration, like those with a large hiatus hernia, significant obesity, patients who are pregnant, or those with diabetes that affects stomach emptying, gastroparesis, even after observing the standard fasting times, you might add extra measures.
Like what kind of measures?
Things like giving clear antacids shortly before anesthesia to neutralize stomach acid, or medications that reduce stomach acid production, like H2 receptor blockers, Begemfol, ranitidine, though less used now, or more commonly, proton pump inhibitors, PPIs like omeprazole or lansoprazole, either the night before and or the morning of surgery.
Moving to liver disease, what are the key assessments needed preoperatively?
Firstly, you need to know the cause of the liver disease if possible. Then check for potential complications. Are there clotting factors affected? Is their kidney function okay? Are there any signs of hepatic encephalopathy, which is confusion due to liver failure? Elective surgery should definitely be delayed if the patient is having an acute flare-up of their liver condition, like acute hepatitis or cholangitis, infection of the bile ducts.
How does the physical exam help reveal the severity of liver disease?
You look for clinical signs like ascites, fluid accumulating in the abdomen, dilated surface veins suggesting portal hypertension, which could mean esophageal varices, signs of poor nutrition like muscle wasting, often linked to low albumin, or significant peripheral edema and sodium water retention. These all indicate significant liver dysfunction and impact perioperative management and risk.
And the overall risk of surgery for these patients?
Patients with established cirrhosis undergoing major surgery face a very high mortality rate. Scoring systems like the MELD score, model for end-stage liver disease, can help predict mortality risk in non-transplant surgery settings for patients with cirrhosis.
What if alcohol addiction is the cause of their liver disease?
Encourage reducing intake preoperatively, but if they have severe physiological dependence, medically supervised alcohol withdrawal management is crucial before elective surgery. This is to prevent delirium tremens, which is a life-threatening alcohol withdrawal syndrome that can occur postoperatively if not managed proactively.
On to the genitourinary system, specifically thinking about patients with chronic renal failure, chronic kidney disease.
The main focus here is on stabilizing the underlying conditions that might be driving the renal failure, such as diabetes, hypertension, or heart disease. Key electrolyte imbalances that are common in renal failure, like metabolic acidosis, low calcium, and critically high potassium levels, especially potassium above 6 millimol, must be corrected before elective surgery.
And for patients who are on regular dialysis,
You need to liaise with the renal unit. Ideally, schedule their last dialysis session just a few hours before the planned surgery time. And always check their bloods after dialysis, but before surgery, particularly FBC for anemia and UNEs for potassium and fluid status.
chronic anemia is really common in kidney failure, isn't it?
It is, often due to lack of erythropoietin production. But surprisingly, it's often well tolerated perioperatively, especially if the expected blood loss from the surgery is minimal, say less than 500 milliliter. If optimization of anemia is needed, for example with iron or EPO, it should be guided by the renal team well in advance of surgery. Preoperative blood transfusion just for chronic anemia in elective cases is rare and generally requires hematologist input.
What about urinary tract infections? UTIs.
Simple UTIs must be treated with antibiotics before elective surgery, particularly for procedures where post-operative infection would be absolutely disastrous, like orthopedic joint replacements or vascular graft surgery. In emergency surgery, if a UTI is suspected or confirmed, start appropriate antibiotics but proceed with the necessary surgery, ensuring good fluid management and urine output post-operatively.
Let's talk about endocrine and metabolic disorders now, starting with malnutrition. How is that assessed?
Often initially screened using BMI. A BMI below 18.5 kilomolar per indicates impaired nutritional status, and a BMI below 15 is associated with significantly increased hospital mortality risk.
So nutritional support is crucial if someone's malnourished before surgery.
Yes, the source emphasizes that nutritional support, ideally provided for a minimum of 2 weeks preoperatively, is generally needed to see a real impact on reducing postoperative complications like wound healing problems or infections. If you anticipate the patient won't be able to eat normally for a prolonged period after surgery, you need to plan for alternative feeding methods like tube feeding or parenteral nutrition beforehand.
Obesity is also a major metabolic factor influencing risk.
Definitely. Morbid obesity, which the source defines as a BMI greater than 35, significantly increases the risk of various postoperative complications, wound infections, blood clots, respiratory issues, and technical challenges during surgery. Advise patients on diet and exercise. Ideally, elective surgery is delayed for weight loss if feasible and safe, but if not possible, proactive measures are absolutely essential.
Like what kind of proactive measures for obesity?
Measures to reduce the risk of acid aspiration during anesthesia induction and enhance prophylaxis against deep vein thrombosis, DVT, as obesity is a major risk factor. Table 21.4 explicitly lists obesity as a key risk factor for VTE.
Obstructive sleep apnea, OSA, often goes unrecognized, but the source links it to higher rates of major adverse cardiac events in patients who have other comorbid risk factors.
That's right. Clinical screening tools, like the PSA P-score mentioned in the source, can help identify patients at high risk for OSA, guiding who needs referral for formal sleep studies, polysomnography. The challenge, particularly in urgent surgery, is that you might not have time for full diagnostic studies or treatment initiation.
If severe OSA is diagnosed before elective surgery,
Studies suggest that using regular nocturnal CPAP, continuous positive airway pressure therapy, for at least 6 weeks preoperatively can reduce perioperative risks associated with OSA. You must discuss the specific risks of surgery and anesthesia with the patient and plan the anesthetic technique and postoperative monitoring strategy carefully, often involving a high dependency or critical care bed.
diabetes mellitus is incredibly common and needs careful management.
It needs meticulous control preoperatively, along with managing its associated complications like cardiovascular and renal disease. For elective surgery, an HbA1c ideally below 69 millimole, which is 8.5%, is recommended by many guidelines, though optimal targets can vary. Address high cholesterol too, usually with statins, as diabetics are inherently high cardiovascular risk.
Are there practical tips for managing diabetics on the day of surgery?
Yes, schedule them first on the operating list whenever possible to minimize the duration of fasting. Adjust their usual anti-diabetic medications, oral drugs, or insulin based on specific local or national guidelines. This often involves omitting doses or reducing insulin. Monitor blood sugar levels frequently, often hourly, during surgery and recovery. For major surgery or patients with difficult to control diabetes, a variable rate intravenous insulin infusion, VR3, sometimes called a sliding scale, is often necessary to maintain glucose control.
Adrenocortical suppression from long-term or recent high-dose steroid use is a potential endocrine emergency perioperatively.
It is. If a patient has taken oral steroids equivalent to more than 5 milligrams of prednisolone daily within the last month or so, or sometimes longer courses further back, they are potentially at risk of adrenal suppression. They will likely need supplementary stress dose steroid cover with their anesthetic, and possibly for a short period afterwards to prevent an Addisonian crisis, acute adrenal insufficiency. The source appropriately credits Thomas Addison for his seminal work on adrenal gland conditions.
And what about those rare neuroendocrine tumors mentioned?
Conditions like pheochromocytoma, producing catecholamines, carcinoid tumors, producing serotonin and other vasoactive substances, gastrinomas, viopomas, and insulinomas require very specific preoperative medical management, always in close liaison with endocrinology specialists. This is crucial to block the effects of the hormones they secrete and prevent potentially life-threatening crises, like hypertensive crisis or carcinoid crisis, during anesthetic induction or surgical manipulation.
Moving across to hematological disorders now, anemia is frequently encountered preoperatively.
It is. If a patient develops new anemia, defined in the source typically as hemoglobin below 130 GL, and is expected to have significant surgical blood loss, over 500 millilo, the underlying cause should be investigated before elective surgery. If it's due to correctable deficiencies like iron or vitamin B12 folate, treating these preoperatively is ideal if time permits.
What about patients with known chronic anemia, like from kidney disease?
As we touched on, it's often surprisingly well tolerated physiologically, especially if the anticipated blood loss from surgery is minimal. Preoperative blood transfusion solely to top up chronic anemia in elective cases, expecting less than 500 milliliter loss, is rarely indicated and should always be guided by a hematologist, weighing the risks of transfusion against the benefits. Local hospital policy will dictate which cases require a group and save blood sample versus having fully cross-matched blood units available.
The source specifically discusses managing patients who refuse blood transfusion, citing Jehovah's Witnesses as an example.
This requires a very clear, respectful, and detailed conversation during the consent process, well in advance of surgery. You need to establish exactly what blood products, if any, are acceptable to the patient, and discuss alternative strategies to minimize blood loss and manage anemia, things like meticulous surgical technique, cell salvage, collecting shed blood during surgery, washing it and reinfusing it, or the use of antifibrinolytic drugs.
And clarifying the refusal.
It's absolutely crucial to clarify if their refusal of blood products stands even in a life-threatening bleeding situation where transfusion might be the only way to save their life. The entire discussion, including the agreed plan and the limits of treatment, must be documented meticulously in the patient's notes. The Royal College of Surgeons provides valuable ethical and practical guidance on this complex area.
Thrombophilia, an underlying predisposition to forming blood clots, is another important hematological risk factor.
Conditions like factor V Leiden mutation, which is quite common, or deficiencies in natural anticoagulants like antithrombin III, protein C, or protein S, significantly increase a patient's baseline risk of developing blood clots like DVT or PE, especially after surgery. These patients need specific discussion with a hematologist to tailor their VTE, venous thromboembolism, prophylaxis plan.
And for everyone else without known thrombophilia.
A general DVT risk assessment is essential for virtually all surgical patients, based on a combination of patient-related and procedure-related factors.
What are some of those common DVT risk factors listed in Table 21.4?
Things like age over 60, obesity, major trauma or surgery, especially involving the abdomen, pelvis, or lower limbs, anesthesia lasting over 90 minutes, being immobile for more than 3 days, pregnancy or the period shortly after childbirth, puerperium, having varicose veins with associated phlebitis inflammation, using estrogen-containing contraception or HRT, smoking, having active cancer or undergoing cancer treatment, significant medical comorbidities like heart failure or inflammatory bowel disease, admission to critical care, and of course, a personal or strong family history of previous blood clots.
How should hormonal contraceptives be managed around surgery given the estrogen risk?
Progesterone-only pills or implants are usually considered safe and can be continued. For combined pills or hormone replacement therapy, HRT containing estrogen, the small increased risk of thrombosis needs to be weighed against the risks of stopping, like unplanned pregnancy or return of menopausal symptoms. Guidelines like NICE Guidance NG89 referenced often suggest considering stopping estrogen-containing methods 4 weeks preoperatively for major elective surgery, but this needs individual discussion with the patient.
Bleeding disorders like hemophilia, von Willebrand disease, or conditions causing low platelet counts also obviously need careful management.
Absolutely. Any known or suspected bleeding disorder requires preoperative consultation with a hematologist. They will advise on specific management, which might include administering clotting factor concentrates or other agents like DDAVP for von Willebrand disease around the time of surgery. The source knows Erich Adolf von Willebrand, who first described the commonest inherited bleeding disorder.
Okay, nearly through the systems. Moving to neurological and psychiatric disorders. How do you handle essential medications like those for epilepsy or Parkinson's disease?
Anticonvulsants and anti-Parkinson's drugs must generally be continued without interruption throughout the perioperative period. Stopping them abruptly can be dangerous, leading to seizures or severe off periods in Parkinson's and hindering the early mobilization needed for post-op recovery.
How do you manage that practically if they can't take tablets?
Schedule these patients early on the theater list to minimize fasting periods. If a prolonged period of being unable to take oral medications is expected after surgery, you need to plan for intravenous or other alternative routes of administration beforehand in discussion with pharmacy and the patient's neurologist if necessary.
Lithium, used for bipolar disorder, is a bit different though, isn't it?
Yes. Lithium has a narrow therapeutic index and can interact significantly with anesthesia and fluid balance changes during surgery, potentially leading to toxicity. It's typically recommended to stop lithium 24 hours before major surgery. For minor procedures, it might be continued cautiously with very close monitoring of fluid status and renal function. UNEs.
And what about other psychiatric medications like older antidepressants, the tricyclics, TCAs, or monoamine oxidase inhibitors, MAOIs?
The anesthetist must be informed if a patient is taking these drugs due to the potential for serious interactions with anesthetic agents or vasoactive drugs used during surgery. Irreversible MAOIs are particularly challenging. Safely stopping them requires specialist supervision over several weeks and strict dietary modifications to avoid hypertensive crises. This always needs close liaison with the patient's psychiatrist on a case-by-case basis.
Finally, let's touch on musculoskeletal disorders.
Certain conditions like muscular dystrophies, myotonic dystrophy, and myasthenia gravis require a highly tailored anesthetic approach. This is because they affect muscle function and the patient's response to muscle relaxant drugs used during anesthesia. It's also crucial to specifically ask about any personal or family history of malignant hyperpyrexia, a rare but potentially fatal reaction to certain anesthetic agents.
Rheumatoid arthritis, RA, can pose some unique anesthetic risks, can it, beyond just joint pain?
The biggest specific concern for anesthesia is the potential for instability of the cervical spine, the neck, due to inflammatory damage caused by RA, particularly at the atlantoaxial joint. This instability could potentially risk spinal cord injury during neck manipulation for intubation.
So how is that assessed?
If a patient with RA is symptomatic, neck pain, neurological symptoms referable to the neck, or has a known history of RA affecting the neck, they need preoperative flexion and extension lateral cervical spine x-rays. Figures 21.7 and 21.8 illustrate these views. You're looking for an increased gap between the atlas C1 and the dens bone of the axis C2, which indicates instability.
What other assessments are important for patients with RA going for surgery?
Remember, RA is systemic, so check for involvement of other organs, kidney function, heart, valvular disease, pericarditis, and lung involvement. Interstitial lung disease leading to restrictive lung function. A rheumatologist's input is also vital regarding their specific RA medications, particularly immunosuppressants like steroids and disease-modifying antirheumatic drugs, DRARDs. It's a balance between the risk of increased infection if the drugs are continued versus the risk of a disease flare-up if they're stopped.
Ankylosing spondylitis, how does that impact things?
This condition typically causes fusion of the spine over time. This can make performing spinal or epidural anesthesia technically very difficult or sometimes impossible due to the fused joints and ligaments.
And systemic lupus erythematosus, SLE.
SLE patients can sometimes have a hypercoagulable state, increasing their thrombosis risk. They can also occasionally present airway management difficulties due to laryngeal involvement.
We have meticulously gone through managing specific problems system by system. Let's turn our attention now to assessing overall physical fitness, which the source stresses is absolutely crucial for tolerating the stress of surgery.
How fit a patient is significantly impacts their ability to withstand the physiological demands of major surgery and recover well afterwards. A common, albeit somewhat subjective way to estimate functional fitness is by determining how many MET-T's metabolic equivalent tasks they can manage. Table 21.5 provides examples.
Can you break down what a MET actually represents for us?
Sure. 1 ME is basically the amount of oxygen your body consumes when you're completely at rest. It's roughly equivalent to 3.5 milliliters of oxygen per kilogram of body weight per minute. Activities are then assigned a MET value based on how much more oxygen they require compared to just resting.
Give us some examples from the table.
Okay, so eating, dressing yourself, just basic self-care is about 1 MET. Walking at a moderate pace, say 3 to 4 miles per hour, or climbing 1 flight of stairs is around 4 METs. Going for a short run might be 6 METs. and participating in strenuous sports like squash or skiing could easily be over 10 METs.
The source mentions a sort of threshold often used for lower-risk surgery.
Yes, in many guidelines, particularly from the US and Europe, being able to tolerate activities requiring more than 4 METs, like being able to climb 2 flights of stairs without stopping or walk briskly on the flat, is generally considered acceptable functional fitness for proceeding with lower-risk surgical procedures without extensive further testing.
But you said it's subjective.
It is. The main limitation is that it relies on the patient's self-reporting, and people can sometimes overestimate their abilities or perhaps underestimate due to fear or other factors.
Is there a more objective way using a questionnaire?
The Duke Activity Status Index, or DASI, is mentioned as a less subjective questionnaire-based tool. It asks about ability to perform various daily activities, and the score can be used to estimate their peak oxygen consumption, VO2 peak. However, the source rightly cautions that a poor DASI score doesn't automatically guarantee they will have a poor result on the gold standard objective test for fitness.
Which is cardiopulmonary exercise testing, CPAT. That sounds more definitive.
Correct. If you really need to objectively quantify a patient's physiological fitness, especially before planned high-risk surgery, CPAT is considered the gold standard measurement. As figure 21.9 illustrates conceptually, the patient typically exercises on a stationary bicycle with incrementally increasing resistance, while sophisticated equipment continuously measures their oxygen consumption, VO2, and carbon dioxide production, VCO2, breath by breath.
What are the key measurements you're looking for in the CPAT results? What do they tell you?
The two most important measures derived from CPAT in this context are the anaerobic threshold, AT, and the peak VO2. The underlying principle is that as you exercise harder, your body needs more oxygen. At some point, the cardiovascular system can't deliver oxygen quickly enough to meet the muscle's demand. When that happens, the muscles start relying more on anaerobic metabolism to generate energy.
And that produces lactate.
Exactly. This produces lactic acid, which gets buffered in the blood, releasing extra carbon dioxide. The anaerobic threshold, AT, is identified as the point during the incrementus exercise where you see this disproportionate increase in CO2 production relative to oxygen consumption. It marks the onset of significant anaerobic metabolism and is a key indicator of aerobic fitness and oxygen delivery capacity.
And how do those specific measurements, AT and peak VO2, predict surgical risk?
The evidence, as highlighted in the source, is quite clear now. Patients who have an anaerobic threshold below 11 millokg or a peak VO2 below 15 millokg on their preoperative CPAT are at a significantly higher risk of developing major complications and have higher mortality rates after major surgery. These thresholds help identify those patients who might benefit from optimization or perhaps need consideration of less extensive surgery or require higher levels of postoperative care.
Can fitness actually be improved once you identify someone's high risk based on their CPAT result?
Absolutely. And that's one of the real powers of identifying these patients beforehand. It opens the door for prehabilitation. Supervised exercise training programs, typically lasting around 4 to 6 weeks before scheduled surgery, have been clearly shown to improve a patient's anaerobic threshold and other fitness parameters, and consequently reduce their perioperative risk profile.
What if CPAT isn't readily available? It's quite a specialized test.
It is, and availability can be a limitation. The incremental shuttle walk test, ISWT, is mentioned as a lower-cost, simpler alternative field test. In the ISWT, the patient walks back and forth between 2 cones set 10 meters apart at progressively increasing speeds dictated by audio cues.
How does ISWT correlate with risk?
Research, particularly in areas like esophageal surgery, has shown that failure to complete a certain distance, often cited as around 350 meters, on the ISWT is linked to a higher risk of postoperative complications. It correlates reasonably well with VO2 peak, but is acknowledged to be more affected by factors like patient motivation, as well as sex, age, and height, compared to the direct physiological measurement of CPAT.
So all this detailed assessment isn't just for the medical team to predict risk. It's fundamentally about informing the patient too. Consent is a huge part of this whole preoperative care pathway.
It's absolutely fundamental. Consent isn't just getting a signature on a form. It's a dynamic process, a dialogue aimed at achieving shared decision-making between the patient and the clinical team. In the UK, this process is heavily guided by legal judgments, acts of parliament, and professional guidance from bodies like the General Medical Council and GMC, and the Royal College of Surgeons, as implicitly referenced in Chapter 14 of the source material.
The patient really needs to understand everything. The diagnosis, the options, the risks, the benefits, to make a truly informed choice that's right for them.
Precisely. They need to understand their diagnosis, the nature and purpose of the proposed treatment, any reasonable alternative options, importantly, including the option of doing nothing or having less invasive treatment, and crucially, the specific risks and benefits associated with the proposed procedure in their particular situation, considering their comorbidities and fitness level we've just discussed.
Now that we've covered the whole assessment process in such detail, let's explicitly talk about assessing the level of risk. The source starts with a really fascinating statistic about how overall perioperative mortality has changed dramatically over the decades.
It's actually a remarkable success story in many ways. Despite the fact that patients undergoing surgery today are often older and have more complex health problems than ever before, the overall risk of dying around the time of surgery has fallen dramatically.
How much has it fallen?
The systematic review by Bainbridge and colleagues, published in The Lancet back in 2012, is cited. It showed a staggering decrease in perioperative mortality rates, from estimates of over 10,000 deaths per million procedures back in the 1970s, down to just over 1,000 per million in the 2000s.
Wow, that's more than a tenfold reduction. But despite that overall improvement, there's still a specific high-risk group that accounts for most problems.
This is the absolutely critical point for understanding modern perioperative care. Even with that huge overall improvement in safety, a relatively small proportion of surgical procedures, estimated at less than 15% of the total volume, still account for the vast majority, over 80% of all postoperative deaths in countries like the UK. These are the patients we identify as being high risk, typically defined operationally as having a predicted mortality rate from their surgery of 5% or higher.
Why are these specific patients so vulnerable? What's the underlying physiology?
After major surgery, as we mentioned earlier, the body's metabolic rate and oxygen demand jump significantly. At rest, baseline oxygen consumption is around 110 milliliter per minute per square meter of body surface area, but postoperatively, this can easily increase to 170 millimillim or even higher.
And the high-risk patients can't meet that demand.
Exactly. High-risk patients, typically those with limited heart and lung reserve, simply cannot increase their oxygen delivery sufficiently to meet the sustained increased demand. They develop an oxygen debt at the tissue level. Added to this, you often have factors like hidden ongoing blood loss or significant fluid shifts leading to low circulating blood volume, occult hypovolemia, which further impairs oxygen delivery.
And other factors contribute.
Yes, the body's stress response to surgery can also cause vasoconstriction in the gut circulation, splanchnic vasoconstriction, potentially risking bowel ischemia. And of course, any underlying coronary artery disease or cerebrovascular disease puts them at much higher risk of suffering a heart attack or stroke when placed under the significant physiological stress of major surgery.
The source classifies the factors contributing to this overall risk into two broad categories: patient factors and surgical factors.
That's right. Table 21.6 lists the key patient characteristics that are known to significantly increase perioperative risk. These include things like a history of severe heart, lung, or brain conditions, for example, a recent heart attack, severe COPD requiring home oxygen, or a recent stroke. Also, having advanced aortic vascular disease, being over 70 years old with evidence of limited organ reserve, undergoing very extensive surgery like major cancer resections, or presenting with an acute emergency in the abdomen causing hemodynamic instability like severe peritonitis.
Any other major patient factors?
Yes, also things like suffering massive acute blood loss requiring transfusion of more than 8 units of blood, having proven septicemia with a positive blood culture or a clear septic focus, being in respiratory failure requiring significant oxygen support or mechanical ventilation, or developing acute kidney failure with significantly elevated urea or creatinine levels.
It's important that the source clarifies that age itself, being over 70 for example, isn't necessarily an independent risk factor in isolation, but rather older patients are much more likely to have multiple of these other significant comorbidities, along with increased frailty and that general reduction in physiological reserve as highlighted in the Boyd reference.
Exactly. Age is more of a marker for accumulated physiological decline and comorbidity burden. Surgical factors also make a major independent contribution to the overall risk, as shown clearly in Table 21.7. The complexity, duration, and anatomical location of the procedure itself matter hugely. And as mentioned before, undergoing surgery as an emergency dramatically increases the risk compared to having the same procedure done electively.
Sometimes the patient's underlying condition itself drives the risk, even if the planned surgery seems relatively minor.
Yes, that's a great point. Think about a patient with severe peripheral vascular disease who needs a relatively minor foot amputation. The surgery itself might not be physiologically massive, but the fact they have such severe PVD tells you they almost certainly have widespread systemic atherosclerosis, meaning they likely also have significant coronary artery disease and possibly COPD or kidney disease. It's their underlying health status that drives their high overall perioperative risk, even for a minor procedure.
The comparison shown between unadjusted and adjusted surgical risk in Table 21.8 is absolutely fascinating. Can you explain that?
It really highlights the importance of accounting for patient factors. Unadjusted data simply looks at the raw mortality rate associated with different types of surgery. Table 21.8 shows, for example, that major vascular surgery has the highest unadjusted mortality rate in that data set, around 5.97%. Thoracic surgery is the second highest, around 3.40%.
When you adjust for how sick the patients were.
Exactly. When you statistically adjust these mortality rates to account for the patient's underlying medical comorbidities, essentially, controlling for how sick the patient was going into the surgery, the picture changes dramatically. Vascular surgery's adjusted mortality dropped significantly, down to 0.98% in this example, while thoracic surgery's adjusted mortality actually becomes the highest at 2.28%.
So what does that tell us?
It tells us that patients undergoing major vascular surgery are, on average, significantly sicker with more medical risk factors to begin with. A large part of their high unadjusted mortality risk is driven by their poor baseline health status, rather than solely the inherent risk of the vascular procedure itself. Adjusting for these factors gives a clearer picture of the risk attributable purely to the surgery type.
And this is precisely where specific risk prediction tools become so important in practice.
They are absolutely essential for modern perioperative care. The goal isn't just to vaguely predict if someone might die, it's to quantify the risk as realistically as possible. This is vital for having meaningful, informed consent discussions and facilitating genuine shared decision-making with the patient and their family. Sometimes the calculated predicted risks are so high that the patient or the clinical team might reasonably choose a less extensive surgical option, or even opt for non-surgical management altogether.
The Royal College of Surgeons in the UK has some quite clear recommendations based on predicted mortality threshold assessment.
Yes, they do, as referenced. If a patient's predicted mortality is calculated to be above 5%, the guidance suggests there should be active involvement from a consultant surgeon and anesthetist in their perioperative planning and care. If the predicted mortality is above 10%, the recommendation is that the procedure should ideally be performed under the direct supervision of the consultant surgeon and/or anesthetist, unless the more junior staff involved are demonstrably highly competent and experienced with such complex cases.
And critical care planning.
Crucially, patients with a predicted mortality risk exceeding 10% must be planned for mandatory postoperative management in a critical care unit, HDU or ICU. Identifying these very high-risk patients allows us to allocate potentially limited critical care resources most effectively to those who stand to benefit most and hopefully improve their outcomes.
Table 21.9 lists a whole range of different scoring systems that have been developed to predict risk.
There are many, reflecting the complexity of the task. They've been developed for predicting different outcomes: PGA mortality, specific morbidities like cardiac complications, need for critical care, and validated in different patient populations or for different types of surgery. They range from relatively simple physiological scores calculated at the bedside to complex multivariable models often requiring computer calculation. Examples mentioned include Apache 2, often used in ICU, possum and its surgical specific variants like P-possum or CR possum, colorectal possum, and the widely used ASA physical status classification.
The ASA system is probably the most familiar one globally, despite having recognized limitations.
It is. It's ubiquitous. And while it wasn't originally designed purely as a risk prediction tool, decades of data have shown it correlates remarkably strongly with actual perioperative mortality rates. Table 21.0 clearly shows the steep gradient in risk.
Can you remind us of those approximate mortality rates by ASA grade?
Sure, ASA grade HERD, a normally healthy patient, has a perioperative mortality risk of around near 0.1%. ASA grade 2, mild systemic disease, is about 0.7%. ASA grade 3, severe systemic disease, jumps to around 3.5%. ASA grade 3, severe systemic disease that is a constant threat to life, carries a risk of about 18.3%. And ASA grade V, a moribund patient not expected to survive 24 hours without the operation, has an incredibly high mortality, around 93.3%. The suffix E is added to any grade to denote emergency surgery, which approximately doubles the risk for that grade.
What are its main weaknesses as a risk tool?
The main criticism is its subjectivity, what one clinician considers severe systemic disease. ASA3, might be classed differently by another. It also fundamentally doesn't directly account for the patient's age or, critically, the specific type and magnitude of the surgical procedure being undertaken, both of which we know are major independent determinants of risk. The 2015 updates that added clinical examples to each grade were an attempt to improve consistency, but subjectivity remains.
Lee's Revised Cardiac Risk Index, RCRI, is mentioned as another key, more objective tool.
Yes, this is a very influential and widely validated score, but it's important to remember it focuses specifically on predicting the risk of major cardiac complications like MI, pulmonary edema, VF, or complete heart block after non-cardiac surgery. It doesn't predict overall mortality.
How does it work? What factors does it use?
It uses 6 simple, objective, equally weighted factors that are determined from the patient's history and basic investigations. These are listed clearly in Table 21.10.
What are those 6 factors in the RCRI?
Okay, they are. 1, a history of ischemic heart disease, defined as prior MI, angina, positive stress test, or Q waves on ECG. 2, a history of congestive heart failure. 3, a history of cerebrovascular disease, stroke or TIA. 4, diabetes mellitus requiring insulin treatment. 5, renal insufficiency, defined as a serum creatinine over 177 mmol/L, or about 2 mg/dL. And 6, undergoing a high-risk type of surgery, specifically defined as intraperitoneal, intrathoracic, or suprainguinal vascular surgery.
And the risk increases simply with the number of these factors the patient has.
Exactly. It's elegantly simple. With 0 risk factors, the predicted risk of a major cardiac complication is very low, about 0.4%. With just 1 factor, it roughly doubles to 0.9%. With 2 factors, it jumps significantly to 7.0%. And if a patient has 3 or more of these risk factors, their predicted risk of a major cardiac complication is high, around 11.0%. It provides a very useful stratification of cardiac risk.
The ACS-NSQIP score is also mentioned, particularly its web-based calculator.
Yes, the American College of Surgeons National Surgical Quality Improvement Program has developed a very sophisticated online risk calculator. It uses the specific planned surgical procedure code plus 19 preoperative patient risk factors, like demographics, comorbidities, functional status, to generate personalized risk estimates for a wide range of potential postoperative complications, including death, MI, pneumonia, surgical site infection, and more. It also allows comparison of the individual patient's calculated risk to the average risk for patients undergoing that same procedure in the large NSQIP database.
Finally, under this broad topic of risk assessment, the source discusses how the actual choice of surgical technique can and should be influenced by a patient's specific risk profile.
Absolutely. A surgical technique that is generally considered lower risk overall might actually become relatively higher risk in the wrong patient, depending on their specific physiological limitations.
You mentioned laparoscopic surgery earlier in the context of respiratory patients.
Yes. Laparoscopy or keyhole surgery often involves smaller incisions and less postoperative pain, which can be beneficial for patients with significant respiratory risk as it facilitates earlier mobilization and better coughing. However, creating the necessary neuroperitoneum, inflating the abdominal cavity with carbon dioxide gas, and sometimes requiring specific patient positioning, like steep Trendelenburg, head down tilt, can have significant adverse effects on cardiovascular and respiratory physiology. So laparoscopy might not always be the best option for someone with severe heart problems. Potentially not. The increased intra-abdominal pressure from pneumoperitoneum can reduce venous return to the heart and increase systemic vascular resistance, increasing cardiac workload. The CO2 absorption can also cause acidosis. So, for patients with severely limited cardiac reserve, the physiological stress of laparoscopy might sometimes be greater than that of an open procedure, although this is complex and procedure dependent.
Minimal access surgery, like robotics, seems to be pushing the envelope here in terms of patient positioning.
It certainly is. Procedures like robotic-assisted radical prostatectomy or some advanced laparoscopic colorectal surgeries often require the patient to be maintained in a steep Trendelenburg position. Figure 21.10 shows this position clearly, for several hours, combined with pneumoperitoneum.
What are the risks of that prolonged position?
While it provides excellent surgical access, physiologically it can be very demanding. This position significantly increases pressure inside the chest, impairs lung function, increases pressure within the brain, intracranial pressure, and can increase cardiac workload. In high-risk patients, particularly those with underlying heart disease, lung disease, or neurological issues, this prolonged positioning carries potential risks of adverse cardiovascular events like MI or heart failure, respiratory compromise, or even neurological complications.
Hmm.
Careful patient selection based on their assessed fitness and comorbidities is absolutely essential to minimize these specific risks associated with the technique.
This discussion about high-risk patients and potential complications naturally leads us to the vital role of critical care and outreach services in the perioperative pathway. The source highlights some important findings from the UK's NCEPO reports about when postoperative deaths tend to occur.
Yes, those reports were quite revealing. They consistently found that the majority of postoperative deaths in the UK actually occur more than 5 days after the initial surgery, often after the patient has left the immediate high monitoring environment of the operating theater recovery area and returned to a standard surgical ward.
So, planning for admission to a critical care unit, HTU or ICU, immediately after surgery can potentially be life-saving for these high-risk individuals.
It absolutely can be. Admission to critical care provides a much higher level of continuous physiological monitoring, a higher nurse-to-patient ratio allowing for more intensive interventions, and the capability for rapid response to deterioration that is often difficult, if not impossible, to replicate consistently on a busy general surgical ward.
What does critical care allow you to do specifically?
It allows for the earlier detection and more aggressive, timely treatment of common, serious postoperative complications like myocardial infarction, acute heart failure, respiratory failure requiring ventilatory support, acute kidney injury needing renal replacement therapy, or developing sepsis, all during that crucial early postoperative recovery phase when the patient is most vulnerable.
Perioperative MI, a heart attack occurring around the time of surgery, sounds particularly dangerous based on the mortality figures mentioned earlier.
It is indeed. It carries a significantly higher mortality rate than an MI occurring outside the surgical setting, typically cited as being between 15% and 25%. Post-operative management in a critical care setting allows for things like invasive cardiovascular monitoring, for example, arterial lines, central venous pressure monitoring, the carefully titrated use of vasoactive drugs to support blood pressure and cardiac output, precise fluid management guided by hemodynamic parameters, and specific interventions aimed at minimizing ongoing myocardial ischemia and preventing the development of cardiogenic shock or overt heart failure.
Respiratory complications were also highlighted as a major issue earlier. How does critical care help manage those proactively or reactively?
Postoperative lower respiratory tract infections, like pneumonia, occur in about 1.5% of all surgical patients, but carry a mortality rate exceeding 20%, making them a major concern. Respiratory failure itself, often defined by criteria like needing significant oxygen, having a low PO2 FiO2 ratio, or inability to be extubated within 48 hours, is even more serious, with reported mortality rates between 27% and 40%.
So what can be done in critical care?
Critical care provides the ideal environment for delivering interventions aimed at preventing or treating these complications in high-risk patients. This includes things like elective initiation of non-invasive ventilation, NIV or CPAP, to support breathing and prevent lung collapse, intensive chest physiotherapy, and the use of devices like incentive spirometers, as shown in Figure 21.11, to encourage deep breathing. And of course, if respiratory failure develops, critical care provides the capability for invasive mechanical ventilation.
The source points out a significant gap here, though, between the number of high-risk patients and critical care admissions.
Yes, it highlights a concerning paradox observed in many healthcare systems. The high-risk surgical patients, who we know account for perhaps 80% of postoperative deaths, are historically only admitted proactively to critical care postoperatively in a relatively small proportion of cases, maybe only 15% to 30%.
So NELA recommendations are trying to address this.
Exactly. Initiatives like the National Emergency Laparotomy Audit, NELA, in the UK have strongly advocated for standardizing the care pathways for these high-risk groups, including recommending routine admission to a critical care environment for all patients undergoing emergency laparotomy who have a predicted mortality risk greater than 5%.
That's where the concept of critical care without walls or outreach services comes into play.
Precisely. Intensive care outreach services, ICARs, or equivalent rapid response teams in other systems, are crucial. They recognize that patients on standard wards can and do deteriorate, sometimes subtly at first. Using standardized physiological track and trigger systems, often called early warning scores, EWS, helps ward staff identify patients showing signs of deterioration much sooner.
And the outreach team bridges the gap.
Yes, the outreach team, typically staffed by experienced critical care nurses or doctors, can then be called to review these patients promptly on the ward. They can initiate critical care level assessments and interventions earlier, provide expert advice to the ward team, and facilitate timely transfer to the critical care unit if needed, effectively bridging the gap between the physical critical care unit and the general ward environment.
Let's shift gears one last time now to the purely practical aspects of actually arranging an elective theater list. This involves coordinating a lot of people and resources.
It's all about meticulous planning and communication. You need to match the planned date, time, and location, specific operating theater, with the availability of the entire necessary team. Skilled surgical staff, anesthetic staff, specialist theater nurses and practitioners, as well as ensuring the availability of any specialized equipment, instruments, implants, or support needed from other departments like radiology or pathology.
And getting the list out early.
Absolutely. The finalized theater list needs to be compiled and distributed well in advance to all the personnel and departments involved. Table 21.1 gives a good indication of just how many teams might need to be informed: ward staff, theater teams, potentially specialist nurses, like stoma nurses or diabetic nurses, the anesthetic and surgical teams, including trainees, radiology, pathology, rehabilitation services, physio, OT, social care teams for discharge planning, administrative and scheduling staff, and sometimes specific personnel like those managing cardiac devices.
And locking down essential resources like a critical care bed for planned admissions.
Absolutely essential. If the preoperative assessment identifies a patient as being high risk and requiring a postoperative critical care bed, that bed needs to be pre-booked and confirmed well in advance of the surgery date. It shouldn't be left to chance on the day.
How do you typically decide the order of the cases on the list? Is there a standard approach?
There are several considerations. It's common practice to prioritize patients who are particularly vulnerable to prolonged fasting, like children and patients with diabetes, placing them first or early on the list whenever possible. Sometimes, starting the day with a relatively straightforward, predictable case can help the theater list get underway smoothly and on time.
What else influences the order?
It can also buy time if you're waiting for something specific needed for a later case. For example, waiting for radiology to insert a guide wire for a breast biopsy before that patient comes to theater, or if you need final confirmation that the critical care bed is definitely ready and staffed for the complex case planned next.
How can you make the list planning more efficient in terms of timing?
A simple but effective strategy highlighted is using the specific operating surgeon's actual average time taken for a particular procedure based on their log data if available, rather than relying on generic hospital-wide estimates for procedure duration. This leads to much more realistic and efficient theater list planning and utilization.
What about the practice of having staggered admission times for patients on the day of surgery?
While having patients arrive closer to their scheduled surgery time can undoubtedly improve patient satisfaction by reducing their waiting time fasting in the hospital, the downside is that it significantly reduces flexibility on the day. If an earlier case finishes quickly or a case gets canceled, you may not have the next patient ready and waiting, potentially leading to theater downtime. It's a trade-off between patient experience and operational flexibility.
Finally, let's briefly look at how preoperative assessment works for emergency surgery. The principles must be similar, but the time frame is obviously collapsed.
The fundamental principles are exactly the same as for elective assessment. You still need to rapidly assess the patient's physiological state, understand their relevant past medical history and comorbidities, and identify the major risks associated with the patient and the urgently required procedure. The critical difference, of course, is the severe time constraint. There's often very limited, if any, real opportunity for significant preoperative optimization.
So grading the urgency of the emergency is key.
Yes, that's vital. The NCEPO classification of surgical urgency is commonly used in the UK, and similar systems exist elsewhere, defining cases as immediate, requiring surgery within minutes to save life or limb; urgent, requiring surgery within hours; expedited, requiring surgery within days; versus elective. This grading dictates exactly how much time, if any, is available for assessment and stabilization efforts.
You still start assessment and treatment immediately, even if you know you won't finish optimizing before the surgery has to happen.
Absolutely. You do what you can in the time available. Even a short period of focused resuscitation, giving fluids, correcting critical electrolyte abnormalities, starting antibiotics if sepsis is suspected, and targeted assessment can reduce some immediate risks, although many underlying risks related to chronic conditions will inevitably persist due to the acuity and the lack of time for proper optimization.
And consent in emergencies.
You still need to discuss these residual unmitigated risks with the patient or their family if the patient lacks capacity as part of the emergency consent process whenever possible. Obviously, this might not be feasible in immediate life-saving situations. Summary Box 21.3 in the source material reinforces these crucial points for emergency preoperative assessment.
Is there anywhere optimization can happen more effectively before urgent surgery?
Yes, if the patient's condition allows and resources permit, attempting preoperative optimization in a critical care environment can be much more effective than on a ward or in the emergency department. That higher level of monitoring, staffing, and immediate access to interventions can potentially achieve more significant physiological stabilization in a shorter time frame before they go to theater.
And for these high-risk emergency patients, it's absolutely crucial to predict the likely need for critical care after surgery early on.
Essential. And communicate that prediction immediately to the duty critical care physician or team. Planning for and securing that potential post-operative critical care bed is paramount right from the outset when managing high-risk surgical emergencies.
Wow, we have really, truly gone deep today. Covered a huge amount of ground.
We really have. We've traversed the entire complex landscape of preoperative care, haven't we? From that initial patient encounter, peeling back the layers of their history and conducting a thorough physical exam, including that incredibly important airway assessment, right through to understanding the rationale behind targeted investigations.
We dissected the detailed management of common and complex medical conditions, system by challenging system. We looked at how to assess physical fitness using both simple bedside methods and sophisticated objective tests like CPET. We navigated the crucial process of informed consent and shared decision-making.
And we spent significant time quantifying surgical risk using various scoring tools, really understanding that interplay between patient factors and surgical factors, and how adjusting for comorbidities changes the picture. We even touched upon how risk influences the choice of surgical technique itself.
Then we explored the practicalities of elective theaterless planning, the unique and compressed challenges of assessing patients for emergency surgery, and importantly, the vital safety net provided by critical care units and outreach services for supporting our highest-risk patients through their surgical journey.
You, the listener, have now acquired the kind of granular understanding of preoperative assessment and optimization principles that healthcare professionals rely on every day. It's really this level of detail, understanding the why behind each step, that takes you beyond basic competence towards genuine mastery in this critical field of perioperative medicine.
So to leave you with a thought to ponder, building on all this complexity we've discussed, as medical science continues to allow people to live longer, often accumulating multiple chronic health conditions, and as surgical techniques become ever more ambitious and technically complex, how will the entire field of perioperative medicine need to continue evolving to meet the ongoing challenge of safely preparing and optimizing these increasingly complex patients for the surgeries of the future?